Mosaic is a federally qualified health center. We're a primary care home. So we have services across the tri-counties in Central Oregon. So we have clinics in Prineville and Madras and Redmond, and then several clinics in Bend.
We served about 19,000, I think, last year. So we've grown quite a bit over the course of about 11, 12, 13 years. Bridges Health is a collaborative effort from the community. We think of it as an ambulatory ICU. It was identified, again, through many community meetings and initiatives that there was an unmet need in our community to take care of the highest complexity patients, so that sort of top 3 or 5%, whatever you want to call it, who are utilizing the most of the resources. And so community members from multiple entities came together to start having a conversation about what to do, and decided that we needed to have a center that could help take care of those patients. And so from that was born Bridges Health. Bridges Health is again, kind of like an ambulatory ICU specialty primary care clinic with a very heavily integrated team, multidisciplinary team that includes clinical pharmacy, dietary or nutrition services, behavioral health, community health workers, nurse care management and coordination, obviously primary care providers. We bring in mental health people from outside of the facility to help with that. And then we've got now a behavioral pain specialist as well. So patients are referred from primary care providers. They're identified through, mostly through claims data actually, as being a high risk. They qualify based on a scoring mechanism provided by Pacific Source, which is one of our partners in this. And then that's shared with the primary care providers in the community, and then they identify patients they feel like could really benefit from the program and refer them in.
Our model's a little different than the rest of Mosaic. So in Bridges, all the patients who come in will see the behavioral health consultant at some point in their orientation. So they have an orientation appointment, which kind of explains what Bridges is, and then they see each one of the primary providers, which means they typically would see the PCP, any combination that can happen in any kind of combination, but they'll see their primary care provider, they'll typically see the pharmacist, they'll see myself, to kind of just get a good, complete picture, or the best picture that we can get of that individual. Our day starts with scrubbing our files to see kind of what's happening for our day, who's on our schedules, to kind of prepare. And then we meet as a team huddle. We have all the members of the Bridges team, and we can hopefully talk like we're informed about this particular patient and what may be going on in their life, what each individual member may be doing with them at a particular time, so we can have a consistent message to that patient, and we can respond consistently as a multidisciplinary team. So our goal is about 15 minutes in the morning. My role as a behavioral health consultant is to help the provider, actually the primary care provider, understand some of the dynamics that may be impacting the individual from a behavioral health standpoint. So in the past, I think we've had mental health issues happening with patients that may interfere with their ability to make any progress health-wise. And what we recognize is that these other issues were conflicting with their ability to engage their own health concerns. So as a behavioral health consultant, my job is to kind of meet with them and see, is there something that we can do to help them improve their ability to help their own medical care.
So patient education is a challenging thing, I think, for anybody in the healthcare system, and especially for our patient population, primarily Medicaid, oftentimes with many socioeconomic barriers. So really using motivational interviewing, and something that I've learned a lot while being here at Mosaic, is learning a lot about motivational interviewing and trying to find the patient's goals and to help them meet their goals.
We measure a lot of clinical quality measures, anything from diabetes management, control of blood pressure, and then we have a number of behavioral health focused measures that we focus on too, like completion of SBIRT, or the screening brief intervention, referral to treatment, screening for anxiety and depression, things like that. So we measure those things and look for improvement in scores. We measure patient engagement. In Bridges Health in particular, we measure levels of engagement, so before and during and after the program. We also are looking at, in partnership with some of our partners, resource utilization. So is resource utilization improving from an external perspective for these patients who are in the program?
It's fascinating to me to see how patients respond to behavioral health consulting in primary care. We still have, there's still a bit of hesitancy to involve themselves with anything that's called counseling. So the idea of calling it a behavioral health consultant is helpful. But being able to kind of reach out to a person and say, hi, I'm Steve, I work here, my job is to help improve your quality of life if I can, maybe help see what's motivating you or how we can help you to get motivated with your diet or your blood pressure or anything of that nature. It just seems like we can engage them a little quicker than being able to just refer them out, because we realize that we've lost a lot of people in the referring process. We keep recommending referrals, but they don't necessarily pick it up. It may be because they're hesitant, afraid, concerned, apprehensive about seeing a mental health person, and getting a chance to come in and just meet them briefly even is helpful.
But I think that engaging and getting them to trust you, to show up for appointments, that's huge. Sometimes folks just don't show up. And so that's why we have our community health workers to call and check and say, hey, we saw that you missed your appointment today. Lang's really wondering how you're doing. You want to reschedule.
The role of the clinical pharmacist in primary care here at Mosaic is unique, I think. A lot of clinical pharmacists work in a disease state specific model, in the sense that they'll manage hypertension or diabetes or hyperlipidemia. And here we work on a referral-based model. One of our big goals in the Bridges Clinic is trying to get patients off of a lot of their medicines. These are patients with chronic mental illness commonly, socioeconomic challenges, and then complex physical illnesses. And those three things in combination, patients get put on a lot of pills, and a lot of those side effects cause them to have challenges managing their day-to-day life because their pills start managing them. And so getting people off of a lot of their pills is helpful. And in our clinic, unfortunately, a lot of patients are on controlled substances, and so helping with that is important too.
The outcomes are really amazing, actually, of what we're seeing with patients, with having a wraparound program, with having multiple team members to have an approach. So how I view it is that a patient is in the center, and then we wrap services around them.
I do think that it's easier for me to access some people that I probably would never have had a chance to access in the past because they're here. And because the design of the whole program allows me to get quicker access to people, and maybe right on the spot when they wouldn't necessarily request or be willing to go out on their own and seek care. We can offer it to them here. Seems like a huge benefit to me.
Integrating behavioral health into primary care can come with a lot of growing pains, I think, and having leadership on board is absolutely salient. I think that's one of the biggest pieces that we had in the beginning that made it, that opened up the doors for us to really do what we're doing. One of our leaders actually discovered the model and say, hey, this is what we want to do, go get trained. So that was lovely, to have their vote of confidence and support. So having their buy-in in the beginning helped create kind of a domino effect.
It's a privilege to take care of patients. It's an extra privilege to take care of underserved patients, and having additional resources to help us do this important work is critical. When I look at our integration model, that's one way to try to help better care for a population when there's a lot more being piled on to the work we do in primary care. So I think being able to integrate provides hope that it's not going to be such a mountain to climb when you've got additional team members to help with that load.